So thank you. Good afternoon. And looking at the microcirculation is indeed something attractive. And importantly, we move to a slightly different world, which is at the tissue level. The fact that we have to realize that what is the limiting factor for oxygen to go to a given cell is not really the speed at which a red blood cell will flow into this vessel, but much more the diffusion distance between the given cell and the nutritive capillary. And so if providing that the capillary is perfused, this distance will be of paramount importance. We have to realize that the control of the blood flow in the microcirculation is done by many factors that are totally different from what we expect, meaning that the local factors are very important, and the endothelium itself is playing an important role, because you can see that if you stimulate the endothelium, there is communication of the information up to 1 millimeter, which is at the level of the microcirculation, which is capillary is 10 microns. So it's a huge distance that is crossed by this information, so that it's a possibility to fine-tune the distribution of flow at the microvascular level. So we have quite a lot of evidence for alterations in experimental sepsis, and this is basically characterized by a decreased vascular density, and more importantly, absent or intermittent flow in some capillaries, while others are well perfused, leading to heterogeneity of perfusion, and this has been shown in many, many models. The consequence is the increase in diffusion distance, and this will impair the oxygenation of this piece of tissue in septic shock. A very good example of the loss of communication is expressed in this trial. You can see here the change in capillary transit time heterogeneity. So when you put an animal into a stress condition, which is hemorrhage inducing bleeding, the animal tried to respond by trying to improve the matching between microvascular perfusion and microvascular oxygen demand, so that indeed the heterogeneity will decrease in hemorrhagic conditions. In sepsis, even though the animal is bled, the heterogeneity will increase further, so that the system is not responding adequately and is providing too much flow into some areas and not enough flow in some other areas. And this heterogeneity increase is associated with the impairment in critical oxygen extractions in these conditions. What are the mechanisms implicated? Well, several, and one, again, mostly is the impaired backward communication, because indeed the system does not communicate correctly, and so the system doesn't understand that some areas need more flow and some areas need less flow. Also, rolling adhesion of white blood cells, and platelet to endothelium also decrease sensitivity of the endothelium to vasoconstricting as well as vasodilating substances. And as a result, we have areas that are not perfused enough and in which the flow is lower than the need, and we have tissue hypoxia here. And on some others, we have excessive flow for the demand, and in these conditions, we have the highest VO2 we see in sepsis. In humans, we have indeed these alterations. This is normal microcirculation with here venules, here capillaries, and you can see that indeed the flow in all these capillaries is well preserved. What we see here is in a patient with septic shock. We can see in the venules, the flow is well preserved. We can see here in these capillaries, the flow is quite high. We can see in this area, we can see these capillaries here with no flow at all. So you can see that here, for a couple of seconds, there is absolutely no flow here in these vessels. And this means that indeed, this area is fully hypoxic. So we have indeed a decrease in the density of these vessels. We have a decrease in perfusion in the capillaries compared to control conditions. And we have also an increase in the heterogeneity. And from our initial description in 2002 up to now, we can see that there are a lot of trials exactly showing exactly the same aspect, with decrease in vascular density, decreased perfusion in capillaries, and heterogeneity between areas. What are Other trials have shown relatively similar aspect by using different techniques, but showing exactly the same aspect of decreased endothelial reactivity, which is more severe in patients with sepsis compared to volunteers. And again, this has been shown again and again in literature, even though there are less data because this has been less studied than with the other techniques. What is the relationship with outcome? Well, it's quite importantly associated with a poor outcome. You can see that the more severe the alterations in the microcirculation, the higher the mortality in these patients. Perhaps a very important trial, even though a small size one, they were looking at difference between septic shock survivors and septic shock non-survivors. And you can see that the non-survivors have a lower perfused vessel capillary density. The proportion of perfused capillaries was also lower, and heterogeneity was increased in these patients, suggesting, again, these alterations are very important. Perhaps very important also, they show that the speed at which red blood cells are flowing in perfused capillaries is not different between survivors and non-survivors. This indicates strongly that the convective aspect at the level of the microcirculation is much less relevant than the diffusing capacity in these conditions. So we need to pay attention to this, because this means that if we want to improve the microcirculation, we should recruit these non-perfused capillaries rather than increasing the speed at which the red blood cells are flowing into the already perfused capillaries. And with other techniques, the endothelial dysfunction also has been shown to be associated with the outcome and also with the severity of organ dysfunction in surviving patients. Importantly, it is a dynamic factor. It's not just a witness that your patient is going bad and you have nothing to do. Obviously, here we can see that when you resuscitate your patients and you evaluate the microcirculation a few hours after, so 3 hours after resuscitation strategy, when the microcirculation improves, the next day you have an improvement in SOFA score. When you have a deterioration or improvement, then the next day you have an deterioration of the SOFA score. And also you can see that over time, we have here an improvement, but not a normalization of the microcirculation in survivors, while in non-survivors dying in shock or in multiple organ failure after resolution of shock, there is no improvement in the microcirculation. So the big question, of course, is it something specific to the microcirculation, or is it just a consequence of major alterations in these patients who are, by the way, more severe, and by the fact you don't have anything else to do for these patients? Well, if you look at the microcirculatory perfusion and systemic variables, there is no major relationship. You can see no relationship with blood pressure here, and even though it was slightly significant here, you can see that the link with oxygen delivery is quite loose, because for a given DO2, you can have a poor microcirculation as well as a very good microcirculation. So obviously, a very loose relationship with oxygen delivery. And here again, the same kind of relationship here with the velocity in the microcirculation, which is not related with cardiac index or blood pressure in these patients. When you try to achieve the surviving sepsis campaign goals in the bundles, or at least the bundles that were effective up to recently at least, you can see that there was no difference here in the microcirculatory alterations there. And again, comparing hyperdynamic shock to normal or hypodynamic shock, there is no difference in severity of the microcirculatory alterations in these patients here. And so again, hyperdynamic shock or normal dynamic shock, there is no difference here. So the probably very important question to address at some point is it really a primary event or an adaptive phenomenon? Some people say, if we have alterations in the metabolism due to cellular toxicity of the sepsis, then of course the microcirculation will just shut down because there is no reason to provide flow to an area that do not need oxygen. Well, it seems not to be exactly the case. And even so, some people advocate that the narrowing of the veno-arterial difference in oxygen may reflect a decrease in oxygen extraction because the cells do not consume oxygen. It seems not to be the case, because if you look at least in experimental conditions early on, you can see that the extraction in a perfused capillary is increased in sepsis, not decreased. You can see in black it is increased, meaning that as long as a capillary is perfused, the cells are really avid to receive oxygen and consume oxygen in sepsis, and metabolism is increased by many other factors. The problem is then the distribution of oxygen and not really the use of oxygen at the mitochondrial level. We have described heterogeneity in perfusion. Interestingly, there is also heterogeneity of expression of hypoxic factors. And the most important aspect is that there is a totally co-localization of both factors. So the area here in red that are expressing a lot of hypoxic factor are the areas that are also not perfused, suggesting the link between perfusion and hypoxia in these animals. Here again, you can see that there is also a proportionality of the alterations in redox states and the proportion of dysfunctional vessels. The higher the proportion of dysfunctional vessels, the higher the expression of redox states in these animals. And once again, a co-localization of these factors. You can see blood flow is heterogeneous, and hypoxia is heterogeneous also. And hypoxia is occurring together with the alterations in redox states exactly in the places where the blood flow is the most altered. Also, the kinetics have to be taken into account. And you realize here that in animals, first there is a decrease in perfusion, as is here by laser Doppler, and then only secondly, there is an impairment in the function in the brain of these animals with a decrease in the evoked potentials here that occurs only after the decrease in blood flow. Also in humans, we may have some indirect evidence. We looked here at the relationship between the pCO2 gap under the tongue, so in the tissue pCO2 gap, and the perfusion of capillaries in the tongue also. And what we observed is that there was an inverse relationship with an increase in the pCO2 gap with the decreased flow. Again, if flow was matching metabolism, this would be that we have a decreased flow because we have a decreased metabolism. If we have decreased aerobic metabolism, this means that we just have a decrease in VO2, and of course, also a decrease in VCO2. This means that we expect, if it is flow adapted to metabolism, to have a flat line, which is not the case. We had an increase in pCO2 gap, meaning that the flow was totally inadequate regarding the oxygen requirements. And when you manipulate the system, when you improve the perfusion here in the liver by giving it a butamine, you have also an improvement then in redox states that occurs in response to this improvement in the microcirculation. And in humans, what we had is that when we have an improvement in microvascular perfusion, there was also an improvement in the lactate levels that was totally proportional to the improvement in the capillary perfusion. And again, in humans, when we have an improvement in microcirculation, the next day we have also an improvement, an improvement in the microvascular, in the organ dysfunction in these patients. While when there is no improvement in microcirculation, there is no improvement in organ function. So altogether, this suggests that it's really a primary event that is occurring in the microcirculation, leading to alterations in organ function, and that potentially reversing it may be something desirable. So when we think at how to reverse it, which is, of course, one of the key aspects and key elements there, we have to remember that oxygen transport is driven by diffusion much more than convection. So we need to think at how to recruit the microcirculation. I do not have the time to cover all the interventions, so I will not go into details there for all these kind of aspects. I just want to highlight one of the possibilities, which is the modulation of the endothelial nitric oxide synthase. Indeed, this is probably one of the important enzymes regulating locally the microvascular perfusion. And one of the ways to do this is by giving vitamin C. Vitamin C, indeed, has been shown to be effective here in these animals, and when they give vitamin C just after the peritonitis, but also 1 day after peritonitis, there was improvement here in microvascular perfusion in these animals. So, okay, but this is an antioxidant. What is the link with endothelial nitric oxide synthase? Well, it is interesting to realize that vitamin C is effective and needs or requires the untitled nitric oxide synthase to be efficient. You can see here in animals who were knocked out either for neuronal nitric oxide synthase, for inducible nitric oxide synthase, or untitled nitric oxide synthase. When animals were knocked out for neuronal or inducible nitric oxide synthase, the effect of vitamin C was still preserved with some improvement in the microcirculation in these animals. However, when animals were knocked out for untitled nitric oxide synthase, vitamin C was not efficient anymore. So obviously, we need to have this enzyme efficient to use this with these drugs. How can we manipulate the untitled nitric oxide pathway? Well, interestingly, nitric oxide metabolism is dependent on the endothelium of the untitled nitric oxide synthase. And when the enzyme is efficient, meaning when it is coupled, then the presence of oxygen together with arginine is leading to citrulline and nitric oxide. But this requires many cofactors, including especially the presence of BH4, tetrahydrobiopterin. In some conditions, this enzyme may be uncoupled with the absence of the BH4 here. And in these conditions, even when oxygen is present and arginine is present, unfortunately, the enzyme cannot be efficient and does not produce nitric oxide anymore. On the other hand, this same enzyme is producing at that time oxygen radical species, and this can be, of course, leading to further injury to the endothelium, but also to the environment, meaning the other cells in the tissue around it. There are some data showing that indeed this system may be impaired. Here, this is a recent trial looking at malaria, and it was in Southeast Asia, of course. And what they looked at the BH4 here, which is markedly decreased depending on severity of malaria. In moderate malaria and in severe malaria, you can see it is mostly altered here. And interestingly, BH2 is increasing here in these conditions, meaning that the ratio between the active tetrahydrobiopterin and the inactive one is fully altered here in these conditions of malaria, and especially in severe malaria, compared to healthy controls. Can we try to reverse it by giving tetrahydrobiopterin in some conditions? It seems that it can be done. Here is something we did in the lab, and we observed that administration of tetrahydrobiopterin in these sheep was improving the perfused vascular density here, and also the proportion of perfused vessels in these animals, with 2 administrations, one here and one here. And also, interestingly, there was an improvement in the heterogeneity. There was an increase in heterogeneity in control animals that did not occur in the animals that were receiving tetrahydrobiopterin. And perhaps more importantly, there was not only an improvement in the microcirculation, but there was also some other improvement. There was an improvement in the organ function of these animals. There was an improvement in the permeability. These animals required less fluids than the other one. And there was also an improvement in the survival rate, survival duration of these animals when they were given tetrahydrobiopterin. So perhaps this is really something very attractive. Probably not yet ready for a prime time, but at least suggestive that this can be a way or a pathway to be tested at the bedside in future trials. Can we monitor easily the microcirculation at the bedside? I will go once again in depth to the CO2 gradient to monitor the microcirculation, because the very important aspect to realize is that we have areas that are not perfused. You saw the image. Red blood cells are not flowing. So in these conditions, when there is no flow here, how can we figure out that we have this accumulation of CO2 that can be transmitted, because there is no perfusion, to the venous output of the organ? Fortunately, even though oxygen diffusion distance is very short, the diffusion distance for CO2 is much longer, so that indeed CO2 can diffuse to these perfused vessels here, and so that indeed it can be captured here at the output of the vessel, so that indeed we can have an increased CO2 gradient. And this has been shown indeed in animals that the tissue PCO2 increased much more than the venous PCO2. But nevertheless, you can see that venous PCO2 here increased compared to normal values. So it can be used to capture the increase in CO2 levels, even though monitoring CO2, tissue CO2 will be even better than the veno-arterial PCO2 gradient. And you have seen this paper already, and so once again, we can use this VCO2 gradient to monitor the microcirculation, and it also is a very good mirror of the heterogeneity index in these conditions. So multiple experimental trials have indeed suggesting that microcirculation is altered in sepsis in particular, and is associated with the organ dysfunction. These alterations are due to several factors, and unfortunately, the classical resuscitation tools are not very efficient in improving, fully restoring the normal microcirculation. Modulation of endothelial nitric oxide synthase seems to be promising, but not yet ready for a prime time. And monitoring the microcirculation can only be achieved by two ways at this stage: the video microscopy, which is a little bit cumbersome in some conditions, and the PCO2 gradient, which can be achieved in all patients easily. Thank you very much for your attention.